Good afternoon and welcome to the WAVY Digital Desk. I'm your host, Sarah Good. Today we're going to be speaking about the anti-obesity medication market. We're going to be talking about who are they for, their impact, and how they're used in a comprehensive weight loss plan and program. There was another story that was out yesterday. Stephanie Hudson talked about the shortage of Ozempic's medication, and then I focused on the comprehensive weight loss plan that patients like Loretta from Sentara use to take off weight that they have in a comprehensive plan. So anyway, I'm going to bring on Dr. Christina Cradaville from Sentara Comprehensive Weight Loss Solutions, who's going to speak with us more about these medications, about the market that's expanding, and more. Hi, Dr. Cradaville. Thank you so much for joining this afternoon.
Hi, no, thank you for having me.
Absolutely. For people that don't know, we did a report. I linked it in Facebook if you're watching on Facebook. If you're on wavy.com, it's available there, and it's linked, on the homepage as well, where we discussed, how these weight loss medications are used, and then also how one patient of yours used them on her own journey, and still is using them on her journey to, not just weight loss, but health and, having a healthy lifestyle. But just to start, can you just tell us a little bit about your background in the field and just tell us a little bit about your practice?
Oh, absolutely. So I've lived in this area a long time. I was in the military and got interested in obesity medicine probably in 2010. Tried to start programs for our active duty members. And then when I got out of the military in 2014, I went into private practice and started within the practice I was at, I started an obesity medicine, then I just called it a weight loss program. And then that really kind of got me started in the field. So, and from there, I joined Sentara in 2020, and I've been here since. So.
And in your plan, just going to the actual, clinic that you all have and sort of you walking me through it, can you tell me a little bit about what comprehensive means now?
Sure. So, in my mind, when I talk to my patients, when they first meet them, I tell them, this is about treating the disease of obesity. It's about getting you to a healthy state, and a healthy state means something different for everyone. It's not a particular weight. And part of that would be medication options, depending on what other disease processes the patient has going on, or what has been tried in the past, or maybe there are things we can't use based on health issues. But at the foundation of any comprehensive treatment plan for this disease is lifestyle intervention, and that's something I emphasize strongly, because we have to start to talk about behavioral interventions. We have to start to talk about what's going on, what attachments or non-attachments there are to different either events or foods. Everybody has potentially different triggers, things like that we can talk about. So lifestyle, behavior, we talk about medication, and then we also talk about the bariatric surgery, because the bariatric surgery is the gold standard for treating the disease of obesity, getting diabetes in remission, and that's what we have our long-term outcomes data on. We don't have that on the medications yet. I anticipate these medications are very promising, especially the injectable medications. They're life-changing for people, and I'm very excited to include them as part of the plan. But again, it's only part of the plan.
Right.
So.
And that's a big part of, Loretta's journey, just talking about one of your patients. And I'm sure that, that accounts for a lot of your patients, that it's only one step in this process that, you all set up for them. Talking about some of these injectables, I think a lot of people right now are hearing about them, whether it's in pop culture, the news. It sort of seems like terms and medications like Ozempic and Wegovy or semaglutides, like those are all buzzwords right now that people are hearing a lot, whether it's through where they're getting their news or where they're reading about, different celebrities. But I just would, if we could just start the beginning and sort of break down, what are they doing at the base of it? You mentioned in our conversation, their, GLP-1 is sort of what they focus on. Can you just talk a little bit about what these medications really are?
Sure. So they're actually polypeptides, which are analogs, recombinant DNA analogs to a human hormone called GLP-1 or glucagon-like peptide. And so that's where they are, that's where they're acting at those receptors. So the thought being that there's maybe a lower level of this hormone in patients who have certain metabolic conditions, to include the disease of obesity. And by simulating this hormone, we're not only helping to basically correct an underlying metabolic issue with the patient that leads to weight loss, decreasing fat stores we're finding inside of organs, so inside the liver, around the heart, inside the kidneys, also the fat stores that live in our abdomen. Also, but what we notice is that it makes us feel fuller, faster, longer. We are not eating as much, which is where nutrition becomes very important, because the quality of the calories that we're consuming is far more important when you're not eating as much, to make sure that you don't go into a malnourished state. So that's what the medication is doing for our diabetics. They're also, they improve glycemic control through mechanisms. So they're really pretty fantastic. So.
And you talk a lot about how these newer medications that are on the market are able to actually target systems in the body, which is what you're talking about, and really make that, what you call like a life-changing, change, really life-changing change for someone. But in terms of their usage, now one is FDA approved for diabetes and one is FDA approved for anti-obesity medication. How do you all distinguish that amongst your patients and sort of figure out what the best medication is for them?
So for my diabetic patients who have the disease of obesity, I talk about if the GLP-1s, meaning Victoza, Trulicity, Byetta, Ozempic, Mounjaro, which also hits another receptor, GIP. I talk about these medications with patients, and I like to set expectations up front that I can't predict what's going to be approved, or I mean, I can a little bit, but I can't predict what's going to be approved or what the cost is going to be to them. Because
Right.
sometimes it is cost prohibitive. We work really hard with patients if they can qualify for assistance programs to get them enrolled. And I have several patients enrolled with assistance programs to get Ozempic when it was cost prohibitive before. And we're seeing excellent weight loss results with those patients. We When it comes to patients who don't have the disease of diabetes, and Wegovy is FDA approved for anti-obesity or weight loss. So Ozempic, FDA approved for type 2 diabetes, Wegovy, FDA approved for weight loss or obesity. Both are the medication semaglutide, that polypeptide. But unfortunately, insurance companies will only recognize one or the other, which creates this supply issue that we're having. Okay, so that we can only the pharmaceutical company can only make so much, in one, I guess, for demand reasons. So anyway, when my patients don't have diabetes, I'll talk to them about something like Wegovy, Victoza, type 2 diabetes, Saxenda is for weight loss or obesity. Both are the medication liraglutide. Mounjaro is for type 2 diabetes. Zepbound was just FDA approved for weight loss. Both are anti-obesity. Both are the medication tirzepatide. So we have to, work our way through these muddy waters of how do we get these medications to our patients while following the FDA approval, since I can't prescribe most of these medications off-label for anything else right now due to the demand. Most of the anti-obesity or weight loss market in the past has been through off-label use of medications to help with weight loss to treat the disease. So it's not an uncommon practice in my field. The tide is turning because we are having more medications. We don't just have Qsymia and Contrave and that's it, and one called Belviq that's now off the market. But we've got these other medications that we've seen, these injectables. So yeah, the tide is turning that we're going to have more options. As of right now, due to how effective these medications are, patients, rightly so, are looking to, treat their disease and change their life. Um, but unfortunately, we just can't keep up, and I don't see that changing for a couple of years, but we'll keep working to get people on them and get them going as best we can. So
Right. And I do want to say, as life-changing as these drugs are, we've heard, and just to go back to Loretta, as she was the last person I spoke with about this, she says, it takes that bit of an edge off, it gives you that kick to really help you on your journey, but it's not the only factor, obviously, and that's what you spoke about as well. But it does help that want, that hunger a little bit, that it does help you in that plan.
yes, they do. I tell patients the sweet spot is somewhere around 18 months. And then after that, we don't really see a lot more weight loss. Okay. They're still doing their job metabolically. So I don't want to withdraw that medication. That's like saying, oh, my blood pressure is controlled because I'm on my lisinopril, but I'm going to stop my lisinopril because my blood pressure is controlled. No, your blood pressure is controlled because of the lisinopril. So similarly with these medications, we've corrected an underlying metabolic issue. If we withdraw that, the body's going to revert back, and that's where we're seeing weight gain, weight regain, or weight recurrence for patients. It's not, the onus is not just on the person, it is also on the metabolic disorder they have that we're trying to treat. And obesity is very misunderstood as a disease. And that's something as a country I know we're continuing to work on. But in terms of in terms of what they do long term for people, when I tell patients I don't want to make the same mistake with these medications that we did 20, 30 years ago with the bariatric surgery, probably 30 years ago. I'm showing my age, but we did the surgery, patients are going to do great, go on your way, and then we saw this weight recurrence for people, and people were seen as failing the surgery, when it's not that. You're not failing the medication, you're not failing the surgery, you may be a non-responder, or we weren't actually educating patients on what I said earlier, that the foundation for this is lifestyle intervention. So we've got to give the patients the tools, and the patients have to meet us halfway, like how Loretta was saying, follow what we're doing, follow what we're saying, we really want patients to know that um, if the lifestyle intervention isn't made, if we're not training and teaching in the correct way how to use these medications, how to use the bariatric surgery for long-term success, then we're going to see the same thing happen, where patients are going to start to have weight recurrence again, and the medication's not working anymore, when really it was the treatment, the comprehensive treatment plan wasn't really put into place how it should have been.
Interesting. So, you don't want people to obviously get discouraged or complacent at that 18th month period when they're not seeing that maybe drastic shift in weight, but just know it's still working, it's still there. It's just, is it regulated, or your body sort of lost that immediate amount of that difference maker, or sort of what's that?
Yeah, we really don't know
Mm-hmm.
100%. What I tell patients, my patients is, when we hit that mark, don't, like what you said, don't get discouraged. Let's talk about what the issue is. Is the hunger drive coming back? I've got some medications maybe we could try that could help with that. Is it a behavioral issue, or is nothing else changed? And now we need to maybe look at stepping up treatment. So just like some people are like, I've been on the same, and I'm going to use blood pressure again. I've been on the same blood pressure medication for years. I don't know why my blood pressure, I haven't changed anything. I haven't changed my diet. I haven't gained any weight. Why is my blood pressure going up? Well, sometimes we just got to change the game a little bit and add something or change to a different medication. I anticipate the same thing is going to happen with some of these medications, and we'll just have to shift to another one, and maybe we'll see the results start again. But I also like to, like I said, I like to manage expectations a little bit. Just 10% body weight loss is considered successful weight loss. 10% means a lot to different people. For some, 10% is 10 pounds, 12 pounds. For some people, 10% is 30 pounds. So it's one of those things that we have to mitigate, that just because it's not, we have to, I guess we have to, our goals have to meet kind of halfway on what the healthy state is versus numbers.
Right.
So when it gets to I am not losing any more weight. And I explained, well, you're metabolically you're healthier. Biomechanically, your knees don't hurt, your back doesn't hurt anymore. Your sleep apnea is gone. Your BMI is 29. I understand you want it to be 25, but what does BMI really mean? That's a whole nother conversation. So what really is our goal here now? And the goal shouldn't be, I want to, and I always joke, and I'm not trying to be flippant, but we all want to fit in our high school jeans. Who knows if that, is that really and that's where
Right. Is that the indicator of health, that you have to have?
weight loss versus obesity. So, and treating the disease of obesity is where we need to focus our energy when it comes to these types of medications.
And I do want to talk about the use of these medications for people that have a healthy BMI or that seem to be healthy in all cases, at least in terms of, what we've heard of, again, to go back to social media. And you and I talked a little bit about this, but for people who are using these medications or doctors that are prescribing them or whatever the situation might be, I mean, what are the negative side effects or things that could happen for a healthy person to utilize these medications?
My biggest concern for people who are using these medications who are at a healthy BMI or body composition, who don't have any comorbidities, is malnutrition, really, because really they're just not consuming enough calories, or consuming far less than they would just by changing some dietary choices or adding exercise. And again, we're talking about people who are a healthy BMI, not people, so BMI 25 or less, not people who have a BMI of 27 and greater with, obstructive sleep apnea or high cholesterol or something. These are people who are otherwise healthy. There's no reason to be on these medications. Really, that's a lifestyle intervention there. Okay. Now there may be people who have a healthy BMI who do have other things going on that may require medications like this to improve, those other disorders, but they don't have the disease of obesity. So we're not using them for that reason. But people who are looking just to lose 10 pounds, which I totally understand. I mean, it's part of making, us feeling like who we are, and it's part of our self image. I'm not putting it down. It's just, that's not what these are for. These are far more powerful. They cannot go unmonitored. They can cause patients to have bowel obstructions. They can cause patients to have pancreatitis. If they're not monitored, patients can go into liver failure if they're not getting the proper nutrition, dehydration if they're not able to keep up with their fluid intake, and then they go into an acute kidney injury. There's a lot of things that if they aren't properly administered and monitored, that there's some scary consequences that could occur, certainly. And with these compounding pharmacies, not to open that Pandora's box, but we just don't know what's in them. And so the FDA, the Obesity Medicine Association, the American Society for Metabolic and Bariatric Surgery, the Obesity Society, all have statements against their use. I mean, it's just
right. So if you're seeing off-brand or generic Ozempic, there's no such thing.
There's no such thing. Semaglutide is a polypeptide owned by Novo Nordisk. Do you really think Novo Nordisk has given that out for someone else to use and make money? No. So I don't know who's making it, how they're doing it, but I wouldn't be injecting that into my body. So.
And, the other side of this that I found really interesting in our conversation is, and just to give a stat here is, Goldman Sachs research and, other financial companies have been doing research on this market that has been expanding rapidly. And they're saying it might reach globally $100 billion by 2030. They're also saying 15 million Americans will receive anti-obesity medicine, treatment for chronic weight loss, but that's of 105 million, patients that are either obese or going to be overweight by 2030. So, I mean, to me, that's a huge disparity in medications that exist, the amount of Americans who are going to take the medicine, but then the amount of Americans who probably could take some medicine and they either don't have access to it or maybe don't have education about it. I mean, how do you explain that, huge amount of people that aren't utilizing some of these medications?
That is the $1 million question. So I have a lot of patients who, want to do it on their own, is said a lot. And um, I, I understand, but the disease, it's a disease. And convincing people and even some providers that obesity is a disease is still something that we're working on. And so I think I told you the statistic during our talk that 45% of Americans have the disease of obesity, and less than 1% receive medication for the disease. 9% of Americans have type 2 diabetes, and over 90% of those patients receive medication. So 45% of our population, and what the disease does is not only decrease quality of life, but it decreases one's ability to participate in society and with your family. It's just, there's so many societal impacts that obesity has that we are ignoring. Um, that I think just through this sort of thing, education, talking about it, being honest and upfront, people asking questions. Um, there's a lot. I mean, it's more. I think it's a more controversial topic than it should be, because it's a disease. I don't know how else to put it. So,
Right.
but
There shouldn't be this shame around, figuring out what's
right.
best for you as well.
Yeah, it's I think because there's so many factors that go into what causes it, and we don't understand that. We like to put blame on the patient. It's happened with other diseases. Mental health back in like the 90s, 80s and 90s was the hot topic of, it's not the patient's fault they have depression,
Mm.
and it was a stigma. And we've come a long way with that. And this is
Right.
that next
I mean,
disease.
so much so that behavioral health is a part of your process for
Yeah,
people.
exactly. Yeah. So,
Mm. Well, going forward, and I, don't want to take up too much more time. We're almost out here, but, what is your sort of message for people? You sort of said it there, but, for maybe staying up to date with what's coming out in the future, or, if they themselves sort of need to figure out what that plan is for them. I mean, what's the first step some people should take in their journey?
the first step, is to talk to your doc, talk to your primary care doctor. And poor primary care doctors, they're so overwhelmed. But there are places like Sentara, and there are other comprehensive centers in the region that can help. It's a lot to be put on one of these medications and not have a good plan in place about how you're going to continue to treat the disease like from a holistic standpoint. But it can at least starting the conversation is important. And if you receive resistance, there may be a way to find another way to get a referral. Um, but I tell patients, I don't want people to give up on themselves. I think Loretta is the perfect example of how far she has come. I mean, she is just inspirational. And she wants to put that out there in the world, that she was in end stage obesity, what we call the end stages, and she was able to come back from that. So we have ways of treating this disease. It's not too late. We can do it, but it does take a lot of work, and it's a long journey. Usually, depending on the stage, it can be anywhere from 1 to 3 years. So just and then it's I always joke, the hardest part about weight loss and treating the disease of obesity is the maintenance. So we don't want to forget about keeping the disease in remission. And so that's where a center like what we have, I see my patients on an annual basis who have reached their healthy state every 6 months to a year, depending on what medications they're on and what stage they're in. And so we're able to, after we get them, healthy, so we're able to keep up and keep track and make sure that we're not losing ground. So,
Right. And then the last thing I want to ask, for people who are otherwise healthy, but they are in that category of wanting to find solutions. What's the best place to start? Is it the same thing? Figuring out what's best for you every day, that nutrition aspect, figuring out
Yeah.
what sort of is that culprit that maybe you're yo-yoing around.
Yeah, the overweight state, the 25 to 30 BMI, is neglected right now because we're so overwhelmed by by patients who have obesity with a BMI of 30 or greater. But similarly to pre-diabetics, I think that we are ignoring a little bit that 25 to 30 BMI. So people who really know, okay, I'm developing the disease of obesity. I want to slow it down and stop it, or put it in remission. Again, there are medications not as strong as the injectables that could be considered, but first with that lifestyle intervention and really taking a hard look at what the day to day is so that we're able to make sure that the next step of adding something like a medication would be appropriate. So,
Well, thank you so much, Dr. Credible. I mean, is there anything else that you really want people to know, whether about the anti-obesity medications or about some of these other lifestyle, adjustments?
um, I feel like I talked a lot, but no, I just want people to know that there are treatment options and there are providers out there that want to help, and there's a whole community of us obesity medicine doctors who are fighting to make sure that the treatment options become more accessible and available to a wider group. So, um, don't give up on yourself, and there there is a way. So there is a light.
Well, thank you. And you did not talk too much. And this is honestly, this is what this forum is for, to sort of get into some of these nuances. And I know there's so much more that we could cover, in this conversation. So hopefully it's a conversation that continues with people either watching or, taking it as motivation or sort of, educating themselves on options. But thank you so much for giving us, more of your time. I do want to say before we go, just to anyone watching, the link is in the bio, link is in the comments, excuse me, on Facebook if you're watching there. If you're watching on WAVY.com, check out the rest of the article and information that Dr. Cradaville gave me and also from Loretta's journey. So Dr. Cradaville, thank you again.
Yeah, thank you, Sarah. Have a great day.
You too.